Hello, everyone, and thank you so much for staying with us here at Africa Simplified. I am Emmanuel Ossai, and I host a podcast. I'm lecturer in religion and politics in the Global South here in the School of Global Affairs at Lancaster University in the UK. And I'm actually very pleased to be joined today by a special guest, and she's joined us all the way from Texas in the USA. She's Dr. Esther Ajayi-Lowo, and she's going to be discussing an important topic with us, maternal health. But also, this is a continuation of a previous discussion that I had with Dr. Ogechukwu Williams, who joined us from the University at Buffalo. And we considered previously maternal health in colonial and post-colonial Nigeria. And we actually drew on the text, the book, Birth Politics, which she wrote recently. A very good work that I was recommending at the time that everyone should read. So we're going to be discussing a similar topic, but also from a slightly different perspective and context, given the slightly different work that our guest is doing. So she is an assistant professor of Women and Gender Studies at Texas Christian University in the USA, and she holds a PhD in multicultural women's and gender studies from Texas Women's University. And so Dr. Ajayi-Lowo has also taught at Texas Women's University and Spelman College in Atlanta, and she's worked with the U.S. Foreign Mission in Nigeria, as well as other governmental and non-governmental organizations on several issues like gender, human rights, health and development, and she's done this so well. And among other topics, she's written about Black maternal health, and she's written about childbirth epistemologies, as well as global reproductive justice, and she's written about global decolonial pedagogies, and she's actually published quite a lot. And I've also looked at some of her work, and today we're going to be discussing a recent journal article that she published about the Safe Motherhood Initiative. So this is a health policy of the World Health Organization. And we're also going to be discussing, I think, but of course it depends on our guest, her book manuscript. So at the moment she's writing a book, and it is titled Decolonizing Childbirth, Mothers, Midwives, and Modernity in Nigeria. So I would like to find out what she's doing, and I'm sure our guest would be very pleased to inform our audience what the work is about. But this is actually an ethnographic exploration of the contemporary African Indigenous birth in epistemology. So we'll talk about this as well. And I'm hoping that by the time we finish, we'll also conclude with some recommendations for our governments in Africa as they relate, I think, especially to maternal health. So Dr. Ajayi-Lowo, it is a privilege to have you, and I thank you very much for your time.
Thank you.
Right. I'm actually going to start with something that I found out from the paper which I read recently, published in the Meridians. I'm referring to your journal article. And it's actually on a sad note because when I saw it, I wasn't pleased. And I'm sure this is how other readers would feel. But you did say that in 2007, you had a sad, life-threatening experience in one of the Nigerian public hospitals. And this has somehow actually shaped your advocacy for women's reproductive health. I was hoping you could share with us just before we discuss other things, please, if you don't mind.
Yes, thank you. And I think that it's very important because, like I wrote in that article, it actually is what actually shaped, right, and continues to shape my scholarly trajectory on maternal health, focusing on Nigeria, but also making global connections to think about Black maternal health more broadly. So it wasn't before that time, before the 2007. So from 2004, I'd been working on international human rights. I'd actually attended the United Nations University in Tokyo, Japan. I did, international certificates in human rights in the UN system. And I'd also been working with women's rights organizations, human rights organizations on the ground. So I've been an advocate of, hey, maternal health, we need to make it available, accessible, affordable, and of good quality. And in my mind, for that to happen, everyone needs to go for prenatal very religiously and also use the Western medical nurses, Western medical midwives, OBGYN doctors, what have you, for their childbirth. So for me, that is development. That is modernity. That is civilization. This is where we are. And that is the safest way to have childbirth. So I wasn't just advocating for that. I also thought, oh, I can also benefit from this and take advantage of it. So just being the first person in my immediate family to have a, university education and all
Yeah.
these other education, just a very scholarly person. I thought also being modern and having a safe childbirth means moving away from everything traditional, everything that has to do with the traditional midwives or just the general African wisdom about pregnancy and childbirth. Because I think now we have the experts who can tell us exactly what we need to do and would have this safe childbirth experience.
Yeah.
But when I experienced it, I got to understand the realities better. Right. So I got to understand that what happens on the ground sometimes is different from the sort of advocacy that we make, the sort of strategies and policies that we make. Sometimes there's usually some disconnect between those policies and the things
Yes.
that happen on the ground.
Yeah.
So I was going to this public hospital, very popular in Lagos, and I was very religious. We'll get there, very series of experiences during the prenatal services. Some things that were supposed to be free on the policy were not free, including you using the restroom, wasn't free.
Really?
You were supposed to see a lot of consultants. They were not available. They were on paper. They were not available. Right.
Yeah.
The crowd was always so long. So we had to go there like 5 a.m. in the morning to pick your number to get online. And I started noticing all these experiences and just having conversation with women who would come back and say, oh, we would sort of share words, share stories. Oh, do you remember the woman who usually sit here? Oh,
Yeah.
I heard she lost her baby. Oh, do you remember the woman who was here? Oh, I learned they lost her. And that was frightening, but I was still hoping that okay, well, things happen, that's life. We gain
Yeah.
some, we lose some. So I was still very hopeful. But what culminated that experience was really sad. So I was not listening to my big aunties about my pregnancy, my mom-in-law. I thought we have the experts. As an educated person, this is
Yeah.
how we're trained. Now I would
Yeah.
say this is how we're brainwashed to move away from our roots, from our identity even, right? And that is what I'll be talking about even when I speak more about decolonizing childbirth. So actually these two works are the same, the article and my book. The
Okay.
book is a progression of the article,
Of the
right?
article,
So
right?
the article is a preface to lay the background, to lay out my argument. And then in the book, I will start giving the evidence to support that overarching argument that I made in the article. Right.
Okay.
So on the day that I went for prenatal usually, and it was over 41 weeks. And they said, oh, this baby is no longer getting enough nutrients from you. We have to induce you so we can save the baby and make sure everything is all right. My mom-in-law was like, well, but this is the first one. So traditionally, the first one usually takes a little longer. Give it
Right.
some time. Can they check if the baby is still okay? Can we wait? In my
Yeah.
mind, I'm like, they are the experts. They know what you're talking about, right?
Mm.
And then even during the pregnancy, she would say, "Oh, do you also want to see these agbebi?" Agbebi is the word for traditional midwives in Yoruba.
Mm.
Right. You want to see these agbebi, your sisters-in-law see these agbebi, and they also go to the hospital. It's just for them to also check you out and provide their own wisdom. In my mind, like, no, this is
Yeah.
2007. Who still does that? Right. She would share her own birthing experiences. My mom would share. But I'm like, well, so if it worked for you then, but these are modern times. This
Mm.
is how women need to be saved now, is by going to these experts and having things done the modern way, right? And
Yeah.
I'm putting the modern in quote and unquote, right?
Mm.
Because now I am, problematizing what that actually means, because it's
Exactly.
more complex than, the very surface level of modernity, right? And then I found myself in a general labor ward after the induction. During the induction, I didn't know what they were doing. They were not explaining to me what was going on. Oh, the labor ward was, general labor ward. Everyone was in different stages of nakedness and uh, labor. So we
Mm.
were like, okay, calling for attention. When a lot of people say, but I experienced it. I
Yeah.
experienced, nurses telling me, would you keep quiet? Was I there when you and your husband were, doing this thing? Right.
No.
And they're passing drips to you, connecting things. There's no explanation. You don't know what it is. Is this epidural? What is this? No one is explaining, right? And
Mm.
you were there, and the doctors are also changing. So there's really no continuity, right? So this one will come and say this, the midwife will come and say something. And so you're actually confused because you're just
Yes.
in between all of these experts who have taken charge, who are now
Mm.
experts over your body and everything, and you're just there. You're not centered as part of this process.
Mm.
Eventually, when they had to, decide to do an emergency C-section, they didn't have everything that it would take them to do an emergency C-section. So they had to send my family members to go get this and go get that. And we all know how Lagos traffic can be.
Yeah.
And then eventually, before they would come back, it was getting late. So one midwife, a new midwife, took over, who was nicer because the initial midwife actually told me, "Oh, there's cap root. I don't think you can have this baby." The OBGYN said, "Oh, no, she's okay. She's progressing." So they were conflicting and they were arguing. The woman midwife was an elderly woman. So she says, "I have more experience than you." The
Yeah.
OBGYN was a younger person. So there
Oh
was that
no.
power authority tussle
Oh
between
my
them.
God. In that context.
And what she told me before she left, she said, "Well, when the worst is going to happen to you," she was telling me this. I was in labor. She said, "When the worst is going to happen with this pregnancy, I won't be here. I will have been off duty." And she was
Mm.
eventually off duty. The new midwife was nicer. The feeling she gave me was that this is more like, a bad case already. We can't continue to wait for C-section. Let us try and see what you can do.
Yeah.
And I'm glad she was there. She helped me, worked with me. That was the first time that I saw someone actually relating with me as a person who
Mm.
was helping me to push and give birth to this baby. So that happened. I was able to deliver vaginally, and the baby was out breathing, a boy, a son, but he wasn't crying, right? And
Uh,
so they had to take him to the ICU to resuscitate him. But my thought is, if they didn't have what it would take to do an emergency C-section,
yeah.
I'm not sure if they have everything it would take to resuscitate my infant,
Yes.
right? And so we lost him about 2 days afterwards. And that got me thinking. And that was just the shift in my thinking. And now I call it the foundation of decolonizing my mind. So it has to start from my mind. I started rethinking everything that I've been thinking about maternal health, my advocacy, the UN system, the international human rights, the Safe Motherhood Initiative of the WHO. I started rethinking them vis-a-vis the wisdom of my mothers, of my mother-in-law, of people around me. I grew up in Makoko, which is one of the popular slum in Lagos State,
I know Marco
where,
Cornelius.
yes, that's where I grew up. That's where I was given birth into and grew up. And I
Interesting.
would see a lot of teenagers. Teenage pregnancy was very common, still is in that area, and I'm doing something different in
Mm.
regards to that because that's my roots. I'm never forgetting it. Teenagers giving birth with these traditional midwives, they had babies, and they've been okay. So I took all of that for granted. My own biological mom had 9 biological children of her own. One she had right in front of me when I was 8 years old, just me and I at home. So I took all of that for granted, that if it could be that good, then with the experts, it should even be better. It should be much more easier.
Yeah.
But I was shocked to experience that, and to also see a lot of people who have been experiencing that around me. If you ask anyone in Nigeria now, you know someone at least
Mm.
who was you've lost to maternal death, or someone who've lost their infants. It's
Yeah.
all around us. So I started taking notes and observing and thinking about, so if we open this up and not shut this door of traditional knowledge about childbirth, if we expand it and have a multi-pronged approach, can we have a better maternal health situation in Nigeria and for all Black, brown people all over the world? So that's that experience that, yeah, started my research on African Indigenous birthing knowledge and practices.
Oh my God, I'm so sorry really to hear this. This is terrible. I'm just, yes, imagining what it would have felt like at the time. Yeah, I'm terribly sorry. This is shocking indeed. I mean, I did read about this in that article, but I thought it might be a good idea to actually understand it a bit better from yourself. And now that you've explained it, I even feel more terrible, I must say.
Thank you for giving me the opportunity to share. I think also
Yeah.
the more I share and think about it, the more passionate I am to do this work, not only scholarly. So I appreciate this opportunity to speak beyond the scholarly space, to engage with people about maternal health in Nigeria.
Thanks for explaining this. So now that you've done, I think I can't help but just ask this question that I really need to ask. So are you thinking, not just based on your personal position about this, but perhaps also coming from the research you've conducted about the effectiveness of a variety of Western birthing systems? So are you thinking that increased recognition as well as adoption of indigenous African birthing systems actually would help to address the maternal deaths we have in parts of Africa? Is that what you're thinking at the moment?
Yes, absolutely.
Right.
Absolutely. Right. Yes. And when I think about it, I think about it in terms of it is another very, very valid form of knowledge,
Okay.
right, in and of itself, right? And it has to start from that epistemological acknowledgement,
Mm.
right? We have to start from there before we can think about, so how do we have them side by side? How do we integrate? How do we also support, right,
Mm.
and reclaim this intergenerational birthing wisdom
Mm.
and prevent them from just going into extinction
Mm.
when there's so much that we can get from it?
Okay. Okay, I'm sure we're gonna get back to that in the next few minutes. But just to ask, so the Safe Motherhood Initiative as a policy, my understanding is that this is actually being applied in different regions, yes, by the WHO. Does it? What is it, by the way? And does it actually recognize the African Indigenous birthing knowledge? Does it recognize
No,
it? Okay,
no, no,
right.
it does not. It
Okay,
doesn't recognize it as a valid form of knowledge. And I think
right.
that's actually the problem. So
Yeah.
there are all kinds of, forms of recognition, quote and unquote.
Hmm.
Like, so sometimes like, oh, well, we also want to think about culture. Oh, okay, let's call them traditional birth attendants. There's some ways like, well, let's use them for some, maybe from some clerical things,
Okay.
until let's use them as some sort of like placeholder
Right.
until we have enough hospitals, until we have enough OBGYN, until everything is affordable and all that. So there's been those kinds of recognition, which for me is flawed because it is not an epistemological recognition. It is not a recognition that, asserts or that recognizes that this is birthing knowledge in and of itself. Right. So some form of recognition will be like, oh, let's train them, right? Let's train
Okay.
them in the Western medical way. And I've been part of such projects, right? And this is the reason that okay, if I can say so for myself, I'm very nuanced in my approach to this work, right? Very nuanced. So in addition to me having advocacy experience with, NGOs and international organizations on maternal health, women's rights, I've also worked with the U.S. Embassy in Nigeria, where we with the medical unit, and we got funded by Kibi Simon Trust, and we would go into places in Lagos states like the slums of Tomorrow Island, and we would train the traditional birth attendants. We would say, "Hey, this is how to sterilize your, equipment.
Yeah.
These are the ways that you will recognize uh, emergencies. These are the ways that you would recognize some birth complications, pregnancy complications. This is when you know that it's beyond you and you need to refer to the hospital."
Right.
These initiatives are great in and of themselves, right? Because
Yeah.
I've been part of that.
Yes.
The missing point there is we do not recognize that they have their own knowledge. So, from our own standpoint, we are the experts, just training them on what to do and wanting to medicalize them,
I
right?
see.
So, there's no reciprocal recognition as they also have their own knowledge. What do they know? What do they do? And how can we come in? We just go in as experts and we train them, right? So, some Safe Motherhood Initiative can look like that. So you would think it's some form of recognition anyway,
Yeah.
but when you look at it more critically,
It's
it is a
not.
recognition that is really not right,
Mm.
epistemologically grounded.
Mm.
There could also be recognition like, well, let's use them now until, or maybe in places where there are no hospitals, where people don't have choices anyways. So
Yes.
maybe, right. So all of these pockets of recognition still needs to be grounded in the epistemological recognition before we can make a way forward. Let me give an example. So
Yeah.
we went to Tomorrow Island and we would say, oh, if you have this pregnancy complication, at this point is beyond you, refer to island maternity, for example, right?
Yes.
The closest, think about the island, and then they'll come through the waters to Tomorrow Island. Tomorrow Island and neighboring islands do not have any clinic as at the time. In fact, the US Embassy chose KB Simon Trust from art to build the first clinic on that island.
I see.
Right. And that was being shared by all the neighboring islands. So we'd say, okay, refer to island maternity. If there's no epistemological recognition, the traditional midwife will refer this woman, pregnant woman, to island maternity. And when she gets there, because I've experienced it also, and when
Yeah.
she gets there, they will say, we don't know all the herbs that you've been using. We don't know where you're coming from. We don't understand what they've done, because they do not recognize that those people make traditional midwives actually know anything. So
Mm.
she would be turned back, she would be blamed, she might be rejected, and
Mm.
and the midwife will be there. They do not recognize him or her as someone who knows anything and as
I
someone who
see.
can give report on
Yeah.
what they have done to this point. Right. So that's the reason it has to start from that, recognizing it as a valid form of birthing knowledge in
Yes.
and of itself.
Mm.
Right. And that's the point that I'm making. And then it can become more practicalized. Any sort of adoption, integration can actually work on the ground, because now we know that, oh, they actually know something. Right. And in my book, I'm providing evidence of the things that they know and they do, from
Yeah.
speaking with a lot of them in Lagos, Ibadan, and Abeokuta, and also speaking with the women who have used their services and who have their babies with them.
Wow. So why in the first place isn't there any proper recognition? Like I'm wondering what the original causes are. So does it have something to do with colonial histories or yeah,
Absolutely.
I see.
Absolutely.
Right.
Absolutely. It has to do with colonial history. And that's the
Mm,
reason I call my book Decolonizing Childbirth. Right.
mm,
It has to do with the colonial roots. And I listened to Dr. Williams' conversation with you. So
mm,
thinking about that sort of take over. Like
yeah.
now, these people are colonized, and part of colonization, one of the roots of it is through childbirth. It's like, oh, your pregnant women are dying, the babies are dying because your traditional midwives don't know what they're doing. This is a better way,
Yeah.
right? This is
Mm,
a better way to do it. So everything that is, Western is regarded as better,
mm,
including childbirthing practices. Oh, so it's better. Now you cannot do it this way anymore. You have to do it that way. And so it started gradually. And one would think, well, so this is post-colonial period. All of
yes.
that should be over. Now we are free from that. But are we actually free? We are
Mm,
not. And a
yeah.
lot of scholars have spoken about that we're not actually free. And scholars like Nglobu Grasheni would say we have what we call coloniality, which is a continuum of these kinds of things,
Mm,
which is continued through for instance, the Safe Motherhood rhetoric, the Safe Motherhood which will say, well, all childbirth needs to be attended by a skilled birth attendant.
it's
And when
killed.
they define the skilled, it is
Yeah.
Western medically skilled.
I see.
So that in itself is like, okay, this is the better, this is
Mm,
the safer,
yeah.
right? And others are marginalized,
They're not
discredited,
skilled.
and even
Yeah.
sometimes demonized, right? No,
Mm,
that's
mm,
that's risky, that's barbaric, that's backward, right? And so we have all of that being carried over into the way that even some activists, like I started out, some activists also make advocacy for childbirth,
yeah.
right? Even in the ways that the government policies approach childbirth, right? At some point in Ondo State, the
Yeah.
traditional birth attendants were being paid to refer every pregnant person back to the hospital.
Ah,
Right.
they were paid by the state.
Yes, they were paid by the state. So like, oh, okay, we just want everyone to get to the hospital, right? Some of these things also can be well intentioned. And I
Mm,
always try to say that the Safe Motherhood Initiative can be well intentioned. But
mm,
it becomes a problem when you have a one size fits all strategy
yes.
that disconnects from indigenous epistemologies and practices, disconnects from culture, disconnects from spiritual beliefs about birth, pregnancy, and childbirth. And then you have
Mm,
all of these disconnects, right?
mm,
And then you are actually presenting one form of knowledge as
yes.
the authority,
Mm,
which is the Western medical, right? And that's where the problem comes,
yes.
right?
Indeed. Indeed. I, I, I would like actually to just encounter myself because I've not come across groups of indigenous midwives like yourselves, both individually or as communities. And
Mm.
I wish I would, but if, I mean, until that happens, if you could just explain to me who these midwives are, what they look like, how they differ from the so-called skilled midwives, and perhaps if you could perhaps comment on this African indigenous birth and epistemology as a concept, and if these indigenous midwives, of course, form the central component of this set of knowledge systems, that would be very helpful. And of course, until I get to meet the midwives. But I think based on what you explained, like about Makoko, and what Dr. Williams did explain, they continue to help very significantly in different parts of Africa, but they're just poorly recognized in many cases. And this, to me, is not very fair, given how much the local population depends on them in several contexts. So, if you could just tell us a bit more about them, and
Yes,
yes,
absolutely,
thank you.
absolutely, right. So I think you're also like, becoming an expert, just by saying, by recognizing that actually the local populace actually depend so much on them, right?
Yes,
And
yes.
and also, if for someone like me, who've had the opportunity to speak with them, speak with the women, speak with the traditional midwives, who I also in the Safe Motherhood Initiative called Indigenous Midwives, right? So you would also see that women have good testimonies of
Mm,
just using them, right?
exactly.
So I'll come to that. So let's start with talking about the African Indigenous birthing epistemology for me.
Mm,
For me, that is connected to African worldview, African culture, African belief, right,
mm,
about pregnancy, not even starting from pregnancy, starting from the pre-pregnancy stage, fertility, fertility treatments, right, pregnancy stage itself, the labor, the childbirth, the postpartum, right. It's more like a long, lifelong process that
yes.
connects with childbirth in general, right?
Mm,
And sometimes it could be as simple as the kinds of food that we eat, right? It could be, oh, this, for instance, most of the midwives, the traditional indigenous midwives that I've spoken with, a lot
mm,
of them will speak about, because they are Yoruba, and I did this in Yoruba language as well, to
right.
ensure that they're able to share what everything that they know with me in their language without restriction. So again,
Mm.
another barrier would be when you're maybe interviewing them in the language that they're not able to express, then all of those disconnects and gaps.
So a
Right.
lot of
And
them would normally use local indigenous languages. Mm,
yes. So to
mm,
think about how they will talk about Ewedu. Ewedu, I
right.
think in the US they call it jute sleeve, right? That Ewedu is very good for
Yeah.
pregnant women. And then because it makes your childbirth like easier, like
Yes.
in their mind, it makes your child like sort of like sleep out, right? And
Mm,
you will see women say, yeah, it's actually it works for me. It could be as simple as that. And then it could be as, spiritually integrated to the level of like, oh, we have to go the spiritual way to do this. We
mm,
have to do some concussion for you. We have to do, sacrifice for you to make sure that this child who we think might be an abiku,
yes.
a child who comes and goes back to the same parents, like to abiku, to make sure that
Mm,
this child comes and stays, right? So you can see how simple it could be, but how it can also progress. These are all the diverse birthing wisdom, right,
right.
that we have, right, which could include sometimes, oh, when the baby is breached, this is how we do it. Could be as
Mm,
simple as them knowing how to use their hand to
yeah.
maneuver to turn the, fetus back to cephalic position where it can come that. It could be as simple as them knowing traditionally that for Africans and for the Yorubas specifically who I spoke with, that one of the safest birthing position is for you to go on your knees, right? Because it enhances childbirth.
Yeah.
And now the medical framework is catching up to that, oh, actually, kneeling or squatting is better than you laying on the hospital bed when you're trying to have
Mm,
a childbirth. So
yeah.
those are African indigenous birthing wisdom and knowledge and practices
Yes.
that are helpful and are continuing to be beneficial for people who use them and who still use them in these
Mm,
contemporary post-colonial times, right? And then you also told me to talk to you more about it, those midwives,
yes.
right? I always try to differentiate them from what the WHO traditional birth attendants. And that's the
Okay.
reason you don't see me call them traditional birth
Bed
attendants. I
attendants.
can
Yeah.
call them indigenous midwife. I can call them traditional midwife, right? Because when
Okay.
something is indigenous to a culture, a root, a language, it's also traditional in essence, right?
Mm, mm,
Right. So these are midwives who have these knowledges by way of carrying it from generation to generation, inheriting this wisdom, this knowledge, these practices from grandfather, grandmother, great grandfather, great grandmother. And
yeah.
I'm using great grandfather, mother, and I'm saying the traditional midwives can also be men and they can also be women.
I was
Because
going to ask that.
that's another thing that I found out in my work. And
Okay.
in my book, I'm writing one chapter, devoting a chapter to the fact that They are not just traditional midwives who are women, but there are men also who have been carrying this. So for us, the Yoruba, it's something that is in the family. So you will find an Agbebi who is a woman, Agbebi, who will say, I inherited, I'll give one example. So she told me, she said, my father is Ijebu and my mom is Ilaje. So she said, my father's house from the Ijebus, they have all this birthing wisdom that I inherited from my dad and from my own paternal uncles and all that. And then from my mom, I also inherited these other aspects of it. So I'm bringing them together. So she's together. So you would see a man and the woman doing it together because it runs in their family. So it is not gendered. They don't have to be just women birthing for women, right?
Yes.
There are also men who do the work. And they're different from the traditional birth attendant because the way the WHO defines the traditional birth attendants is people in the community who help others to have their childbirth. Maybe they've learned it through other people or through apprentice. The missing link again there is that it does not acknowledge that they have knowledge about childbirth. And they have this, what I call the intergenerational knowledge of childbirth. So removing that from that definition does a disservice to it. And that's the reason calling them traditional birth attendant does not actually indicate that they have this intergenerational wealth of birthing experience and knowledge that have been helpful from generation to generation. And continue to find them helpful. And that's the reason I call them indigenous midwives, traditional midwives. Right. And I've been at a conference. Yeah, Dr. William was also there at a conference last year where I presented my work. Dr. William was the chair of the panel. And we wanted every stakeholder to be part of. So we invited doctors, nurses, activists, and every one of us were there. And most of them didn't want us to, especially a midwife, a Western medical midwife, did not want me to call the traditional midwives midwives. So she said they're just traditional birth attendants. The doctors as well, they're traditional birth attendants. You see that there's that, knowledge tussle of, where the authority lies. So me calling them traditional midwives and indigenous midwives is also acknowledging that they have that knowledge. And they are not just birth attendants who have garnered their knowledge from apprenticeship, right? And then when we use that term traditional midwives, it can encompass just anyone. It can encompass someone who didn't have any African indigenous knowledge from their household, who just picked up one or two things and started their traditional birth attendants business. It could also encompass like what do we call them? These auxiliary nurses who has learned stuff, who didn't go to any medical or nursing school or just go to a private hospital and just learn some things for a few months and now say, oh, I'm a traditional birth attendant, right? So to distinguish the traditional indigenous midwives from that is also very important. And part of that is acknowledging that they have this knowledge that they've been carrying over from generation to generation. I hope that answers the two questions.
Does. Sufficiently, yes, it adequately answers, to be honest, and that's wonderful. It's interesting what you said about the midwife, the term, and the contest over who uses it. It's interesting, but I fully do understand it because I think when the so-called skilled midwives start accepting that the others are midwives as well, then this certainly is certainly some acceptance that they're just as good as themselves.
Right. Absolutely.
Yeah, and I get it. So I'm just wondering as well if there's, let's imagine that there's some partnership between like the public hospitals that have the skilled midwives and other skilled medical workers, and then this other set of groups or organizations or midwife communities that are not skilled. So if there's any partnership between these different ones, what would it look like? And would it be that, say, for example, the The skilled ones wouldn't recognize the unskilled. Sorry that I'm using these terms. It's just that I don't know which other terms to use. But what's the partnership like in contemporary Nigeria or in other places that you've visited? Do they even work together?
That's a
Hmm.
good question. That's a good question. And I would like to just give examples because in Nigeria we do not have this national cohesive policy of
Yeah,
how to relate with the traditional indigenous midwives. It
yeah.
varies from state to state. So I just gave an example of Ondo State.
Although,
And then when you think about Lagos State is peculiar in that the State Ministry of Health is making that effort and that initiative to collaborate with traditional birth attendants. That's what they call them, right? And so they're like, okay, we want to interface with them. And some of them have been trained by the Lagos
yeah.
State Ministry of Health. They have
Okay.
their certificates and they will show me their certificates. So they're, going through some medical training. Some of them may have been trained by, maybe the US Embassy. Like I said, I was also part of some initiative
Yeah.
that's also in Lagos State, right? There's also there's this project by Adekweju Jayoba. I haven't followed her in recent times, but I know she was also working with traditional birth attendants,
Okay.
giving them equipment and training them. So in Lagos State, you can say there's that attempt and effort to train and give them certificates, and sometimes even to regulate and say, okay, this is how to do it, and this is how to do it, and you have to renew your certification. And they would also give them what they call referral forms and
Ah.
say, oh, okay, so when you get to this point, this is when you know that this complication is beyond you, right? So you have to refer. If this a pregnant person is HIV positive, you
Yeah.
have to you have to refer them, right? Refer them for blood tests and then refer them to the hospital. This is beyond what you can care for. If this is going on, refer them, right? So you say, oh, okay, they're making that effort, which is good.
Yeah.
And I really do appreciate that. But I would want to see more, right?
Mm.
I would
Mm.
want to see more. Again, it's about knowledge toss. It's about, do we really agree that they know what they're doing in a
Yeah.
lot of instances, right? And when we agree to that, we'll be able to speak with the doctors in the hospitals. We'll be able to speak with the nurses at the hospital. We'll be able to speak with the midwives at the hospital to actually know that these are not just coming from people who have, just give them any herbs that is not measured, that there's no measurement. We don't know what they're drinking. We don't know what's in it, right? That would have to be the case because a lot of those women still get turned back. Like, no, we
Yeah.
cannot attend to you. We
I
don't know
see.
what you have been drinking. We don't know how you got to this point. So we are not taking you. So
Okay.
again, that referral is flawed, right?
Mm.
And the traditional midwives are complaining about that. The women are also complaining about that. So they're sort of like left in the middle. So you
Mm.
know what some of them are doing now,
Yeah.
because they also want to move in between these spaces. And that
Mm.
is what this should actually look like, that freedom to also be able
Mm.
to move and choose where to go for work, right? And so some of them would say, so I would also go to the hospital and register so that if I need them, they don't turn me back. And when I
Yeah.
go to them, I don't tell them that I've been to any traditional midwives
Oh.
because I know they would,
Yeah.
insult me and they may
Mm.
reject me, right?
Mm.
But that needs not be the case because we have to be able to follow up and say, okay, the baby has done this and this and this. Okay,
Yeah.
this is what is happening now. And the baby should also have a voice to say, okay, this is where we are and this is what we need. And they'll be able to take them in as partners in this person's childbirth. And that's what it should look like.
Yes.
Right. So
Yes.
that's Lagos State. In Oyo State, for instance, so the people in Ibadan, they usually have meetings where they call the traditional birth attendants, that's what they call them also. So
Mm.
again, we always take on these language and terminology from
Yeah.
the UN, WHO, and all that, right? But we have our own languages. For the Yoruba, the Agbebi. I'm sure the Igbos will have what they call them. The Hausas will have what they call them, right?
Mm.
So they will have meetings with them, discuss with them, explain to them this is what to do, this is not what to do. That is good, but also not acknowledging that they know how to do anything. So for Oyo State, I haven't seen a lot of training from
Mm.
the state government, and I haven't
Mm.
seen the level of collaboration as I've seen in Lagos State. They don't have all the referral forms and all of that, although the women also find their ways in trying to move in and out.
Yeah.
when they have, the need to do that. The same
Mm.
thing in Abeokuta. So I would say Lagos State is where I've seen. In Ogun State also, it's not, that sort of collaboration um, isn't as deep as the
Mm.
one in Lagos State. But of course,
Mm.
Lagos State also needs to be better.
Yeah.
Right. So those are the sort of collaborations that I've seen and ways to actually improve and enhance them. And what I think about this is that these agbebis and the traditional midwives, because they have their own intergenerational birthing wisdom that they have inherited, and now some of them who have received some medical training are now putting the two together, and that puts them at an advantage. It puts them at an advantage. So in my mind, they are even better because they are, privy to these forms of birthing knowledges and approaches and practices and making use of that.
Yeah.
So how are we not seeing them as knowledgeable?
Hmm. Interesting. That's yeah. That's a question I guess that we'll keep asking. Um, and I guess in terms of any recommendations we might have for Nigerian and other African authorities, you've kind of drawn my attention to the importance of thinking about state level interventions uh, in terms of the different levels of government that we have in different parts of Africa. So you've kind of mentioned Lagos, Ondo, Oyo, just suggesting.
Ogun State.
Yeah, so there could be that level of coordination by the state governments, but also there's like a federal government, isn't it? And then there's also like other local governments. So would you say then that there could be different levels of state involvement in this coordination of the health sector in Nigeria?
Right, absolutely. And
Mm,
because we run a federal system of government, so
yeah.
the states, quote and unquote, are very powerful, right? So they have
Mm,
their own level of uh, power on their
yeah.
own ministries of health and all that. So imagine
Mm,
like all the 36 states and the FCT having this sort of genuine collaboration that
yes.
goes beyond the service level of let's train them, let them refer, but actually taking them seriously as serious, knowledgeable birth attendants. It's going to go a
Mm,
long way. And
mm,
imagine that because it's the state government, ultimately or consequently, the local governments are also involved.
yeah.
Right. So I did Yaba Development Council and then Lagos Mainland local governments in Lagos. And they're also going along with the Lagos Ministry of Health. So it's trickling down to them. So imagine if the Lagos state government sees these people as also knowledgeable, right?
Mm,
It will trickle down to the local government and the health centers,
yes.
right? And
Mm,
then imagine if you have all the states taking that sort of approach, then already we have a national right way of collaborating with them.
yeah.
And then we can also have, the federal government also
Mm,
rethinking the way that they think about traditional birth attendants,
mm,
right? And think about, so what's the difference between people who actually have African Indigenous birthing knowledge and how can we acknowledge them and work with them? And
yes.
so separate the shaft from the real crop, right? And then face these people who have this knowledge and see how they can help us reduce the maternal mortality rate that is just going up. And this conversation would not be complete if we do not mention that, according to the WHO, for 2023, Nigeria lost 75,000 women to maternal death. That's some cities,
It's
right?
massive. Yeah.
Yes, that's massive. And
Mm,
I had a presentation at the African Studies Association conference in November. And that was the time that we're talking about Christian genocide or no Christian genocide in Nigeria. And I'm like, it is high time we started seeing maternal mortality, maternal death as some sort of maternal genocide in itself. Because if
mm,
you're losing 75,000 women yearly, every year to maternal deaths,
yeah.
then there's a big problem. It's a form of genocide in itself. It means that these people are dying and
Yes.
no one is really noticing.
Yeah.
Right. So we would have to really think about what we need to do. And they can really help us. The traditional midwives can help us, and they're doing their best on the ground.
Mm.
But the popular word on a lot of scholarly spaces, on a lot of global spaces, activist spaces, is that, oh, they are the ones killing the women, right? You know, they are mismanaging, women are not going to the hospital, that's why they're dying. And it is blindfolding us to looking at other critical problems. Who is taking count of people who die of maternal pregnancy related issues at the hospitals? Who is
Mm.
taking? And again, even if we say 75,000, how are we sure it is not more than that? Who is counting the people in the remote places? Who
Mm.
is counting the people who don't maybe get to the hospital, or the private hospitals who are not reporting to the state about people who died due to maternal uh, or pregnancy related issue? Who is measuring that? Who is measuring or counting the people who are dying due to abortion related complications,
Yes.
or who have to resort to quack services to procure abortion because it is illegal? Who is counting that? Postpartum stage doesn't stop at the 6 weeks like the Western medical wants us to believe most of the time, because like,
Yeah.
well, it's after 6 weeks, you're good. It extends to like a year period and even more than. So
Mm.
people who die like, 7, 8, 9 months, 1 year after childbirth from the complications of the childbirth, are they being counted? So we can
Mm.
think about a lot of categories of women who do not get counted, but who are dying due
Yes.
to pregnancy related issues and complications and complexities. So let's even say, let's just say, okay, it is 75. It is still a huge, huge number.
Mm.
And if I were a president of a country,
Yeah.
this would be one of my top priorities
Mm.
that I would take so seriously,
Yes.
because women shouldn't be dying through childbirth. They are helping to sustain our world, to sustain our humanity, to
Absolutely.
sustain humanity. So we shouldn't be losing them. We shouldn't be losing infants. I lost one of my babies to that, right? So that shouldn't be the case,
Oh.
right? The
Yes.
number can be so reduced if we open this up the more, if we open it up more. So I have a way of thinking about this. It's
Yeah.
more like what I call double wahala. In Yoruba, wahala is trouble. So
Yeah.
we can translate that maybe double trouble or double
Mm.
jeopardy. When the Western medical approach promises you the best childbirth, right? But you're in a country where it's either you cannot afford it. Some women get imprisoned at the hospital after giving birth because they cannot pay.
Mm.
Right? It's either you cannot access it for one reason or the other. Maybe it's far from you and all of that.
Yeah.
It's either it's not of good quality. You just find yourself in an hospital where they really do not care. You don't even know if it's a private hospital. You don't know the certification of the doctor,
Yes.
right? And you're just there. You're at their mercy. Or it could be a lot of things, right? Or you're there at a public hospital where they don't have what it takes to give you an emergency C-section,
Mm.
right? Or they say, oh, it's C-section, but now you have to pay 200,000. You don't have 50,000,
Yeah.
right? And we've seen cases like that reported in the news. It's always in our faces,
It
right?
is. Yes.
So that promise of that's the best way for you to give birth, it's not being fulfilled. And now Nigeria is having this brain drain of nurses and doctors who are all jackpying, right? And that word is not being acknowledged in the dictionary.
It
Jackpot
is.
one is going out of the country. So we're losing doctors, we're losing nurses, we're no longer having enough doctors and nurses
Mm.
to make sure that this promise of best childbirth at the hospital becomes
It's
a
being
reality.
realized.
But
Yes.
then at the same time, the wisdom that we have carried from generation to generation, we are being brainwashed, told to neglect that. We're being told that it's no longer useful. We're being told that it's backward. It's barbaric, right? You'll be ashamed, maybe as an educated person or who lives in the city, or to say you want to go to a traditional midwife, right? Because we have been told that, oh no, this is 2026. You shouldn't be doing that. So now we're losing on both ends. What is promised is not delivered. What we had is being taken away from us. And so this is contributing to the high rate of maternal mortality.
Mm.
And one thing that I also know is that no one is really paying attention to people who die at the hospital.
Yeah.
There's a lot of cases of medical negligence. that I have been part of, that I've experienced for myself. And I went back to this hospital to ask for my case file. They told me they could not find it. So if I were to sue them at that point in my life, my husband and I didn't have a lot of money. We wouldn't have been able to sue them or anything. So I didn't get the case file or anything. I've had a friend, a first class. So we went to Ife together. OAE. I made a first class in philosophy. She made a first class in architecture. She died in 2011 at UCH Ibadan because someone who is a registrar who is not certified to do C-section decided to do the C-section anyway, cut a major artery, and then sewed that back up, and then she bled to death.
Oh my God.
They haven't got justice till today. It's easy to cover up those kind of deaths that happen in the hospital.
Yeah.
And we are not paying attention to it because we're being, maybe, what would I use to? We're being made to believe that, well, people just die because they don't go to the hospital, because they go to the babies, because they go to the traditional birth attendants. But that's not what I'm finding out on the ground.
Yes.
That's what I'm finding out. So these babies will tell me, we work in this community. So you have been here a few times to attend this clinic with these women, and you have seen them coming in huge numbers. If we are killing them, they would not be coming in huge numbers. In Lagos State, they would say the police is after us. Lagos State Ministry of Health is after us. The local government HMO, head of medical, they call them HMO. I think it's head of medical services at the local government. They're after us. They are watching us. The community is watch. So we have a lot of watchdogs. So we cannot afford to mess up. And the women in the community themselves, they would actually do jungle justice if we've been killing them. But here you see them and you've been speaking with them. So they have a lot of people holding them accountable. But who is holding OBGYNs, nurses, and midwives at yours? Who is holding them accountable?
Yes.
So these are questions that we need to ask. So there needs to be, this is a national calling. It is a calling to everyone, right? It is a calling to activists themselves to know that our activism cannot stop at saying everybody should go to the hospital. Because when they go there, what happens? Do we know? Right. And I'm saying that from my own experience as well. So we need to be able to open up our mind and decolonize our mind that these agbebis, these traditional midwives, they know a lot that we do not know. And that's what I'm using my book, Decolonizing Childbirth, to highlight. I'm providing the evidence that I gathered from them. I'm providing them in that book to say, hey, this is what the women are saying. This is what the traditional midwives are saying. So let's see for themselves. They actually do this. How can we tap into this wealth of experience and knowledge, right, that is being carried? This is the way we've been doing it. And it gets better over the years, over the decades. And it's a lot better now, even when they have all of these medical facilities, medical technologies to tap into.
Yeah.
Right.
Oh my. That is something for me to think about personally as well. As we finish, because I probably am part of the problem too, just in terms of how poorly I recognize the value of some of our indigenous systems. And it's just made me also think about the fact that at times, some of us Africans, not like we want to be part of the problem, but we've been brought up in certain ways that prevent us from recognizing the value of what we have and what's been taken away from us as well. And I've been trying to unlearn some of the things that I've learned over the years about the weaknesses of our systems. And I would say that I'm much better at the moment than I was some years ago. And I'm happy for it. And I hope that subsequently it's even going to be a better me. I'm learning from yourself, for example, from this conversation. And I hope that a lot of others would do the same. So I must really thank you for this. It's a privilege.
Right. Thank you. Thank you. And that includes me as well. It took the loss of my child for me to say, okay, wait a minute. These are bodies of knowledge around me that I've been just trying to move away from because I've been told that they're backward. Right. But I've seen empirical evidence of them working. Right.
Yeah.
Right. Yeah, and when the WHO, part of the thing they say is that, well, there's no evidence, there's no evidence for herbs working, there's no evidence for this. But when you think about the empirical evidence, that also includes the subjective experiences of people who have used it and you seeing that it works for them, right?
Yes,
That's empirical.
it
That's
is.
evidence, right? If you've seen someone who's carried this knowledge from years to years, from background to background, it's been working, that means it's potent, it's valid, it works, right? So, and then when we think about skilled and all that, how do we define skill? Does it have to be based on medical for it to count as birthing skill?
Yeah.
Right, right. And one thing that I'm finding very interesting also, because I'm a trained doula here in the US. So doulas in the US people who are not trained to be nurses or doctors in terms of Western medical training, but they get this certification by just like learning about childbirth, right?
Okay.
So you could actually learn from, doctors could be part of people giving you the learning, midwives, Western medical midwives will be people giving you the words, but you're really not certified as a Western medical midwife or midwife or doctor, right? And
Okay.
then you would have, traditional midwives also, or
Yeah.
like teaching you how to do
Yeah.
things, right? And then it could also be what we call like, birth pilgrimage, which is going on now. African
Ah.
Americans coming to Nigeria, going to Kenya, going
Ah.
to Ghana to learn from the traditional midwives, to learn from the
Okay.
Agbebis, right? And also
Interesting.
putting it together from the things that they have learned from their grandmother, grandfather, and are putting everything together. So we're sharing all of that and training ourselves, and then to be able to advocate for pregnant people and also be part of the birthing circle, right? And from there, I have seen in a lot of ways that the African Americans are doing more of the reclaiming of African Indigenous birthing epistemologies and practices than we are even doing back home.
I see.
Right. So like we need to really wake up. We need to
I'm not
wake up.
surprised. Yeah.
Yes. And I have a
Mm.
colleague who we are working together, Dr. Mohammed Idrisu. He's
Mm.
Ghanaian, and we're doing a lot of oral histories with the traditional midwives. They call them African traditional midwives here in the US,
Mm.
out of the global south, Georgia and all that. And just speaking with them and documenting what they know, how they garner the African traditional birthing knowledge from, and how it's helpful for them here, even in the US.
I
So one
see.
of the things that we think is, oh well, if Nigeria can have enough doctors, enough hospitals, our problem of maternal death will be over. No,
No.
no,
No. Yeah.
right? Because it is not over here in the US,
Hmm.
where they have relatively higher, access to medical care and all of that.
Yes.
Because a lot of these Western medical approaches disconnect from culture, spiritualities, and all that. And birthing is not
Mm.
just medical. Birthing
Mm.
is logical, it's emotional, it's cultural, it's traditional, it is spiritual. So you have to have a holistic framework in
Yes.
order to be able to have that goal of reducing maternal death and infant death. It has to be all encompassing, right? You have to know that if you ask somebody, a pregnant woman, oh, so how are you feeling? You need to be able to say, if you say, okay, put it on a scale of 1 to 10. If she says, well, maybe 2, you have to think about where she's coming from. If she's, for instance, maybe an Hausa from Nigeria in the US, most likely that thing is like 7 or 8 on the scale. But
I
she's telling
see.
you 2 because that's our own cultural way of
Mm.
interpreting pain or talking about pain,
Okay.
right? And I had to learn that myself. I have like a high pain threshold.
Yeah.
So sometimes you cannot measure my pain based on the 1 to 10.
Hmm.
You
I
might not
see.
understand. And I have another experience. We won't go into that today because we can
Okay.
talk forever. Where I
Yeah.
had an ectopic pregnancy that had ruptured in me and I'd been bleeding inside. And they still wanted to send me back home the 3rd time. And I kept saying this was happening. To cut it short, I insisted I wasn't going home, and they checked my blood, and that was when they discovered that I've been bleeding inside and I would have just passed out. After
Ah.
all the operation, I lost one of the fallopian tubes and all that, and another near-death experience, right, for me.
No.
I have
Oh
series of
my God.
them.
Yeah.
So the OBGYN said, he was an elderly man. He said, well, I've been in this business for over 32 years. And in my 32 years of OBGYN practice, I have not seen someone who has had ruptured ectopic pregnancy still standing and talking to me. So in his Western medical frame or mind, it's not possible for me to have had an ectopic pregnancy that has ruptured. And I'm still standing and talking. I haven't passed out.
Yeah.
But I'm an individual.
Oh my.
And each person is an individual.
Yes.
So sometimes the Western medical framework just has this one size fits all. This is how it is. This is how it works. Pregnancy and childbirth is not like that. According to the traditional midwives' wisdom, you have to take it like one pregnancy. Even for one woman, 2 pregnancies are not the same. So these are a lot of things that the doulas, the traditional midwives are taking into consideration that the Western medical framework needs to also learn.
Yes.
Right. So it has to be a reciprocal learning, not just the Western medical training, the traditional, but it has to be reciprocal. There's so many that they can also learn. And I'll be putting a lot of that also when I done writing Decolonizing Childbirth. So I'm in the process working.
Please don't let anything distract you from that project. This is a sincere request because we need this book completed and published for us to see. And I'm actually hoping that we'll come back to this channel to discuss the book once it's published as well. But this has been wonderful, and I know you've given us a lot of time, and I'm so grateful for this because you're a very busy person, and it's a privilege to have the amount of time we've had for this conversation. But yes, thank you. I think we've actually considered quite a lot, if I'm being honest, and maybe our audience might have some questions, which I'm going to be looking out for, and then I could share some with you subsequently. But yeah, I think if there's no other question or comment, this might be a good point to say thank you.
Thank you. Thank you so much for this opportunity. I appreciate it. Thank you. Thank you for the work that you do, like putting this platform for us to share.
Well, thank you for making it possible by responding to my request. I'm hoping that we'll do this again.
Yes, absolutely. After my book is out, I'll be delighted to come back and say more. There's a lot to say, and there's a lot to do around maternal health issue in Nigeria and also for Black people everywhere, including the US, where I am.
Thank you for the good work you're doing.
Thank you.
Yeah.
Thank you. All right.
Well, thank you everyone for joining us, and we look forward to seeing you again next time. Okay, bye-bye.